So if I told you that nearly half of American adults have this ticking time bomb inside their bodies, and that modern medicine is currently failing like 74% of them, you would probably think we were dealing with some incurable new virus.
Right, something entirely unmanageable.
Exactly. But we aren't.
Yeah.
We are talking about blood pressure.
Yeah.
So welcome to today's deep dive. We have a massive stack of sources today. I mean, we are looking at the brand new 2025 ACC hypertension guideline updates, plus these highly detailed clinical pharmacology lectures and excerpts from DePiro's pharmacotherapy.
It is a lot of material.
It is. And our mission today is to really decode this condition.
Yeah.
We want to understand what these medications are actually doing inside your body and honestly examine this massive paradigm shift in the new guidelines.
And it's a critical mission because hypertension is the ultimate silent disease.
Right.
You usually can't feel it at all. But every second of every day, that elevated pressure is just relentlessly damaging the delicate inner lining of the vessels in your heart, your brain, and your kidneys.
Which is terrifying when you think about it.
It really is. And that statistic from our sources, the fact that only 26% of patients actually have their blood pressure adequately controlled, I mean, that is a massive wake-up call for the medical community.
Barely a quarter. I mean, to fix a failure rate that massive, the 2025 guidelines have completely rewritten the rule book on what the danger zone actually is.
Yes, they have.
But before we get into the new rules, my brain kind of needs a refresher on the mechanics.
Sure.
How does blood actually exert pressure?
Our sources give us this foundational equation, right? Blood pressure equals cardiac output multiplied by total peripheral resistance.
That's the one. PP equals CO times TPR.
Okay, so thinking about this like a plumber. If I'm watering my garden, the cardiac output is basically how hard the spigot is pushing the water.
Right.
And the peripheral resistance is the hose itself. So if I put my thumb over the nozzle to make the opening narrower, the resistance goes up and the pressure inside the hose shoots up.
That is exactly it. The physical principles in your body are exactly the same.
If your heart pumps harder or, if your arteries clamp down and get narrow, the pressure against those vessel walls spikes.
And that causes damage.
Exactly. Over time, that high pressure causes these microscopic tears in the arteries.
Oh, wow.
Yeah, and your body tries to heal those tears with cholesterol and scar tissue.
Not good.
No, because that leads to plaque buildup and eventually strokes and heart attacks.
Right.
So to prevent that entire cascade, the medical guidelines categorize the pressure.
Okay, lay it out for me.
Normal is less than 120/80. Elevated is a systolic, that's the top number, of 120 to 129, while the diastolic, the bottom number, stays under 80.
Got it.
Then stage 1 hypertension is 130 to 139/80 to 89. And stage 2 is anything 140/90 or higher.
Okay, but just hitting stage 1 doesn't automatically mean the prescription pad comes out anymore, right?
Oh, not necessarily.
Because the 2025 update requires a blood pressure of 140/80 or higher, but it couples that with a second requirement.
Right, the risk assessment.
Exactly. A 10-year cardiovascular disease risk of 7.5% or higher. And to calculate that risk, they threw out the old standard, the pooled cohort equations, and brought in a brand new tool called the prevent equations.
Yes.
And I have to admit, I don't quite get why a math equation changes the game so much. I mean, what is the big deal?
Well, it changes the game because it forces a shift toward highly individualized risk assessment.
Okay.
The older models, the pooled cohort equations, they relied heavily on broad population metrics.
Like just looking at large groups of people.
Exactly. And because of that, they could easily overestimate the risk for a healthy 60-year-old or conversely underestimate the risk for a younger person who had specific underlying issues.
Ah, so it's a blunt instrument.
Very blunt. The prevent equations look much more closely at your specific clinical profile.
Like what?
Things like your kidney function, your metabolic health, your individual lab results.
That makes sense.
It means doctors are treating the actual granular danger to you specifically, rather than just treating a generic number on a blood pressure cuff.
So let's say you cross that 130/80 threshold, and your prevent score says your personal 10-year risk is high.
Okay.
Before we jump straight to pharmaceuticals, my mind immediately goes to lifestyle. Like, what could someone actually do in their daily routine?
Well, the foundation of treatment is always lifestyle. It has to be.
Right.
The sources emphasize the DSH diet and actively dropping daily sodium intake down to 1.5 grams.
Which is really hard to do.
Extremely hard in modern society. But there is a very specific 2025 call-out regarding how to achieve that, and it's potassium-based salt substitutes.
Oh, I've seen those at the grocery store.
Yeah, they actually lower blood pressure by balancing out the sodium in your body. But our clinical pharmacology lectures attach a massive warning label to this.
Right, the kidney warning.
Yes.
Because the sources say these substitutes must be avoided in patients with chronic kidney disease due to the risk of hyperkalemia. And for anyone who isn't a pharmacologist, hyperkalemia is a dangerous buildup of potassium in the blood, which can trigger like severe heart arrhythmias.
It can be fatal.
Yeah, because the kidneys are supposed to filter out excess potassium. So if your kidneys are damaged, giving them extra potassium is basically like pouring water into a clogged sink.
That is the exact mechanism. It just backs up into the system.
Wow. Okay, so outside of diet, what else?
Now, beyond diet, the guidelines officially elevate stress reduction therapies. They specifically call out yoga, guided breathing, and transcendental meditation.
Okay, I read that in the sources and I had to push back a little in my own head.
Oh, yeah.
Yeah, I mean, can sitting on a mat and doing deep breathing really compete with a pharmaceutical drug designed in a lab?
It absolutely can.
Really?
Yes, because it attacks the biological root of the problem. Chronic stress causes your sympathetic nervous system, your fight or flight response, to constantly release adrenaline.
Yeah.
And that adrenaline keeps your heart, the pump, working way too hard and keeps your blood vessels, the pipes, tightly constricted.
Going back to the plumbing.
Exactly. Yoga and deep breathing physically stimulate the parasympathetic nervous system, which directly neutralizes that adrenaline cascade.
So it's not just relaxing, it's actually changing your body's chemistry.
Literally changing the chemistry.
Okay, but what if someone is past the point of breathing exercises? What if they hit stage 2, that 140/90 mark?
And the strategy changes.
Right, because the new guidelines tell doctors to jump straight to a single pill combination, or SPC, meaning you take 2 different first-line blood pressure medications combined into one physical capsule right out of the gate.
Yes, that's the new standard.
But why not ease into it? Like, why not give someone one drug, see how their body reacts, and then add a second later if they need it?
Honestly, because of human behavior.
What do you mean?
The rationale for the single pill combination is strictly about adherence. Just imagine opening your bathroom cabinet every morning. If a doctor gives you one pill, you might take it. If they give you a second pill to take at night and then maybe a third for cholesterol,
Oh, I see.
yeah, you develop pill fatigue. People simply forget or they get frustrated and they just stop taking them entirely.
That makes total sense. It's overwhelming.
It really is. So combining 2 drugs into one capsule vastly improves the chances that a patient will actually take their medicine. It is a behavioral solution to a biological problem.
I love that. Okay, so if the pressure equation is just pump effort and pipe width, and we are throwing 2 drugs at the problem simultaneously, my plumber brain tells me the easiest fix is just to drain some water out of the system.
Right.
Less water in the pipes means less pressure. Do we have a pill for that?
And we do, those are the diuretics.
The water pills.
Exactly, commonly known as water pills. Thiazide diuretics work by making your kidneys excrete more sodium into your urine.
Okay.
And water naturally follows sodium, so you literally pee out the excess blood volume.
It's draining the pipes.
Draining the pipes. But there is another class called potassium-sparing diuretics, like spironolactone.
Wait, potassium again?
Yes. These work by blocking a hormone called aldosterone, which normally tells your body to hoard salt and water.
Right.
But as the name implies, they spare potassium from being excreted. So we run right back into that hyperkalemia risk we mentioned earlier.
The clogged sink problem.
Exactly.
Okay, so we've drained the water out of the system. But what if the physical pipes are actively squeezing shut? We need a way to block the chemical signals telling them to constrict.
Yeah, that leads us right to the ACE inhibitors.
Okay, the ACE inhibitors.
These are the drugs that end in pril, like lisinopril.
Got it.
They block something called the renin-angiotensin-aldosterone system, or RAAS for short.
RAAS, okay.
The short version is that your body produces a chemical called angiotensin II, which is an incredibly potent vasoconstrictor.
So it clamps the pipes shut.
Very tightly. ACE inhibitors stop your body from creating angiotensin II in the first place.
But they come with a fascinating and highly annoying side effect.
Yes, they do.
Because the sources note that ACE inhibitors cause a persistent dry cough in up to 10% of patients.
Right.
And I was reading this thinking, if I'm taking a heart medication, how does it end up messing with my lungs?
It's a great question. So ACE, the enzyme the drug is inhibiting, actually has a second job.
Oh, it does.
Yeah, it normally breaks down bradykinin and a chemical called substance P.
Wait, substance P? That sounds like something out of a sci-fi movie. What exactly is that?
It really does. Substance P is a neuropeptide that acts as a messenger for inflammation and pain signaling.
Okay.
So when you take an ACE inhibitor, bradykinin and substance P don't get broken down, they build up.
Oh.
And they tend to accumulate right in your airways and your lungs.
Which irritates the tissue.
Exactly, triggering a dry, hacking cough.
So if you are sitting in a quiet movie theater, right,
Yeah.
and you get that persistent tickle in your throat,
Yeah.
you just can't. You might blame allergies or like a lingering cold, but it could actually be your lisinopril.
It absolutely could. And this is why patient education is so vital. Understanding the mechanism keeps patients from panicking that they have some horrible lung disease.
That makes total sense.
But if the cough is unbearable, we have an alternative. They're called ARBs, or angiotensin receptor blockers.
Okay.
These end in sartan, like losartan.
Right.
They block the receptor that angiotensin II tries to bind to, but they don't interfere with the breakdown of bradykinin.
Oh, so you get the blood pressure drop without the cough.
Exactly.
Okay, so we've drained the water, we've blocked the chemical signals. What if the muscles wrapping around the blood vessels are just too stiff? Can we force them to relax?
Yes, and that is where calcium channel blockers come in, CCBs.
How do those work?
Well, to flex any muscle in your body, including the tiny, smooth muscles wrapping around your blood vessels,
Yeah.
your cells need calcium to rush in and trigger the contraction.
Okay, so no calcium, no flexing.
Precisely. If we use a drug to block that calcium from entering the cell, the muscle simply cannot clench.
It just relaxes, the pipe opens up, and the pressure drops.
Exactly. But there are two distinct types of these drugs. Dihydropyridines, like amlodipine, specifically target the blood vessels.
Okay.
They relax them so effectively that the vessels widen significantly. But because the vessels open up so much, the capillary pressure changes, and fluid can eventually leak out into the surrounding tissue.
Which explains the classic side effect.
Oh.
Peripheral edema or swollen ankles.
Right. Gravity just pulls that leaked fluid down to your feet.
Oh.
Yeah. The other type are non-dihydropyridines, like verapamil. These work less on the blood vessels and more directly on slowing down the muscle contractions of the heart itself.
Okay, that sounds good.
It is, but because they also relax smooth muscle in your digestive tract, they are notorious for causing severe constipation.
Oh, wow. Okay, so we have this incredibly diverse toolkit. Diuretics, ACE inhibitors, ARBs, calcium channel blockers. How does a doctor actually decide who gets what?
That is the million-dollar question.
And this brings us to a really profound scientific and philosophical shift in the 2025 guidelines. Because historically, deciding which drug to prescribe often involved looking at a patient's race.
Yes, it did.
For decades, the sources point out that guidelines recommended thiazides or calcium channel blockers as first-line treatments for Black patients over ACE inhibitors.
Right.
And that was because massive population-level studies showed better blood pressure responses to those specific drugs in Black adults.
But the 2025 ACCAH framework moves decisively away from those race-based algorithms.
It's a huge shift.
It is. The scientific consensus now formally recognizes that race is a social construct and ultimately a very poor proxy for underlying genetics.
Okay, so if they aren't using a patient's race to decide between an ACE inhibitor or a calcium channel blocker, what is guiding the pen when the doctor writes the prescription?
It's about treating the individual's specific physiology and their life circumstances. The guidelines point out that the true drivers of disparities in hypertension, which is highly prevalent in Black adults in the U.S., are social determinants of health.
That's DOH.
Exactly. We are talking about poverty, food insecurity, chronic stress, and neighborhood disadvantage.
And the sources mention the weathering hypothesis here.
Yes. The scientific literature refers to it as the weathering hypothesis. It describes the tangible physical toll that chronic social and environmental stressors take on the human body over time. And that is why the prevent equations we discussed earlier intentionally removed race as a biological variable.
So the focus shifts entirely back to the individual's specific risk factors and their actual environment.
Correct. Clinicians are now instructed to look closely at comorbidities.
Give me an example.
For example, if a patient has diabetes, their doctor should prescribe an ACE inhibitor or an ARB to protect their kidneys from long-term damage.
Regardless of their racial category.
Exactly, regardless of race. At the same time, doctors must remain aware of broader population trends, like higher rates of salt sensitivity, while actively screening for and trying to help address those underlying social barriers to care.
That makes a lot of sense. And that individualized precision becomes a literal matter of life and death when we deal with special populations and extreme spikes in pressure.
Oh, absolutely.
I want to look at some of the special ops scenarios from the sources. First, pregnancy.
Very important.
The guidelines are incredibly strict here. The goal is to keep blood pressure under 140 over 90.
Right.
And the 2025 update strongly recommends that low-dose aspirin be introduced after 12 weeks of gestation to reduce the risk of a dangerous condition called preeclampsia.
Yes.
But there's a massive red flag.
Yeah.
ACE inhibitors and ARBs are strictly banned during pregnancy
Completely contraindicated.
because they are teratogenic, meaning they cross the placenta and actively interfere with fetal development. Teratogenic, meaning they cross the placenta and actively interfere with fetal development, causing severe malformations.
It's devastating, so they are completely off the table. We also see highly specific targeting when it comes to neurological protection.
Oh, right, the dementia link.
Yeah, the guidelines heavily reference the landmark SPRINT trial.
Okay.
That trial proved that if your primary goal is to protect a patient against dementia and mild cognitive impairment over the long term, the strict target has to be a systolic blood pressure of less than 130.
That is fascinating. Then there is severe hypertension. The terminology itself has actually changed.
Yes, it has.
The old term, hypertensive urgency, is officially gone from the medical lexicon.
Swept away.
Yeah, it is now just called severe hypertension, which is defined as actually changed.
Yes, it has.
The old term, hypertensive urgency, is officially gone from the medical lexicon.
Swept away.
Yeah, it is now just called severe hypertension, which is defined as a blood pressure over 180 over 120 without any signs of new or worsening organ damage.
Right.
And this leads to an update for hospital care that absolutely shocked me.
The IV meds?
Yes. The guidelines explicitly state that doctors should not use routine IV medications to rapidly lower blood pressure in asymptomatic hospitalized patients.
Which is counterintuitive.
It's totally backwards. The sources say the risk of harm outweighs the benefit. But if someone's blood pressure is over 180 over 120, human nature screams to fix it immediately. Why are the guidelines telling doctors to put away the IV bag?
Because it disrupts the survival mechanism called autoregulation.
Autoregulation.
Yeah. If a patient's blood pressure has been running incredibly high for weeks or months, the blood vessels in their brain and their heart have physically adapted.
Like they've gotten used to it.
Exactly. They have clamped down and adjusted to expect that high pressure just to maintain normal blood flow or perfusion to the tissue.
Oh, so their normal is completely recalibrated.
Right. So if you hook them up to an IV and crash their blood pressure down to 120 over 80 in a matter of minutes,
Your vessels panic.
those adapted vessels can't relax fast enough. You severely reduce perfusion to the brain and the heart.
Oh, wow.
By trying to fix the number on the monitor too quickly, you could actually cause the exact stroke or heart attack you were trying to prevent.
That is terrifying.
It is. That is why a slow oral medication approach over days or weeks is now the preferred method for asymptomatic patients. You must lower the pressure gently so the organs have time to safely adapt.
Okay, but what happens when you've done everything right? You've taken the single pill combinations, you've cut the salt, you're doing the breathing exercises, your doctor has evaluated your social determinants, and the pressure still will not drop.
Well, that brings us to our final frontier: resistant hypertension and genetics.
Let's get into it.
So, resistant hypertension is a very specific clinical diagnosis. It means a patient is failing to reach their blood pressure goal despite taking 3 different medications, including a diuretic at their optimal doses.
Okay, so when a patient hits this wall, the 2025 guidelines recommend screening all resistant adults for secondary causes, specifically a condition called primary.
Well, that brings us to our final frontier: resistant hypertension and genetics.
Let's get into it.
So, resistant hypertension is a very specific clinical diagnosis. It means a patient is failing to reach their blood pressure goal despite taking 3 different medications, including a diuretic at their optimal doses.
Okay, so when a patient hits this wall, The 2025 guidelines recommend screening all resistant adults for secondary causes, specifically a condition called primary aldosteronism.
Yes.
And the sources explain that this is a malfunction where the adrenal glands kind of go rogue, right?
Right.
They produce far too much aldosterone, hoarding massive amounts of sodium and driving the pressure up regardless of what other medications you take.
Exactly.
But if pills truly aren't working, the sources highlight a newly reintroduced interventional procedure: renal denervation.
This is fascinating stuff.
It is. The way I read the clinical notes, it sounds like renal denervation is basically a surgeon going in and snipping the communication wire between overly stressed kidneys and the brain to force them to stop driving up the pressure.
Snipping the wire is a great visual. It's actually a minimally invasive procedure where doctors use radiofrequency energy or ultrasound to ablate or quiet down the hyperactive sympathetic nerves that line the renal arteries.
So they just turn off the panic signal.
By disrupting that panic signal between the kidneys and the brain, the whole system just calms down.
That's amazing.
And looking even further into the future, our clinical pharmacology sources point to pharmacogenetics as the ultimate evolution of treatment.
Right, because genetic variations.
And further into the future, our clinical pharmacology sources point to pharmacogenetics as the ultimate evolution of treatment.
Right, because genetic variations completely alter how your body processes these drugs.
Absolutely.
Like the sources detail how variations in the CYP2D6 gene dictate how quickly or slowly your liver metabolizes beta blockers.
Right.
So if you are a slow metabolizer, a standard dose might build up to toxic levels.
Which is very dangerous.
And there are other genetic variations in a process called acetylation, right? Which affects how you metabolize hydrazine, a direct arterial vasodilator.
Yes. Acetylation is essentially how the liver tags a drug to clear it out of the body.
Okay.
If your genetics make you a slow acetylator, the drug just lingers and can cause wild side effects.
Wow, the implications of pharmacogenetics are just profound.
They really are. Procedures like renal denervation, combined with this level of genetic testing, mean the future of hypertension treatment won't just be individualized based on your medical history or your environment.
Right.
It will be hyper-personalized down to your specific DNA sequence.
That is wild. Well, let's take a breath and recap this incredible journey.
Good idea.
We started with the new, stricter 130/80 threshold and the highly personalized prevent equations. Then we explored the nuts and bolts of the medications, how diuretics drain the pipes, how ACE inhibitors stop the chemical constriction but might give you that movie theater cough, and how calcium channel blockers force the vessels to relax.
We covered a lot.
We really did. We unpacked the massive shift toward addressing social determinants of health rather than relying on outdated race-based algorithms. And finally, we look at the surgical and genetic future of treatment for those who just can't get the numbers down.
And, the relevance of this knowledge cannot be overstated. With nearly half of adults walking around with elevated pressure, statistically you or someone you deeply care about is dealing with this right now.
It's just a mathematical reality.
It is. Understanding the why behind those top and bottom numbers and the how behind the pills in your bathroom cabinet, it empowers you to have vastly better, more informed conversations with your doctor.
Exactly. It is about taking an invisible disease and making the mechanisms visible so you can actually take control of your health.
Well said. And as we wrap up, I want to leave you with one final thought to ponder.
Let's hear it.
We've learned today that hypertension is heavily driven by chronic stress, neighborhood disadvantage, and social determinants. Our body's sympathetic nervous systems are constantly locked in overdrive.
Right.
So if our blood pressure is constantly reacting exactly as it is biologically supposed to react to a high-stress, fast-paced, inequitable environment, is essential hypertension simply a biological disease? Or is it our bodies functioning exactly as designed, waving a massive red flag that the modern world we have built is fundamentally incompatible with human health?
Wow.
What if the ultimate blood pressure medication isn't a pill at all, but a change in how we structure our society?
That is heavy. It makes you look at that silent alarm bell going off inside half the population in a completely different way. I mean, maybe the alarm isn't broken. Maybe we've just been ignoring what it's trying to tell us.